Hello, good evening, everyone. So, today we are going to start one of the very important yet very interesting as well as happening unit, which is the cardiovascular system in the physiology. Now, to start with the cardiovascular system in physiology, we would be starting with the first topic, which is the conducting system of heart. The beautiful thing about our heart is that the heart is supposed to pump until and unless a person doesn't expire. So the tendency of the heart has evolved in such a way that it keeps on continuously pumping blood, both within the heart and away from the heart to the circulation, peripheral circulation, systemic circulation, as well as the pulmonary circulation. So for this, circulation of the blood pumping is essential, and for the pumping of the blood, now the pumping of the heart is a mechanical process. It is an essentially mechanical process. Pumping means the contraction as well as the relaxation. Now for the mechanical function, electric stimulus is essential. That means the action potential. So it is the action potential again that is generating the wave, generating the stimulus, which is enabling the heart to pump, to undergo contraction as well as relaxation. Now, for this to happen, there are certain regions, certain areas, certain structures in the heart which carries out this process. Like here, coming to this picture of the heart, the essential structures in the conduction are the SA node, which we all are very quite aware of. Then we have the AV node. We have the bundle of His and Purkinje fibers. Okay. Now, this in the picture that we are seeing here is the SA node. Now, where is it located? It is located on the right atrium. As you can see, it is located on the right atrium, where the right atrium has a connection or the junction with the superior vena cava. This is its anatomical location. The next structure is the AV node. Now, where is this AV node located? AV node is located posteriorly in context to the interatrial septum. This is the septum. This is the septum between the two atrium. This is one atrium. This is the other atrium. This is the right atrium. And this is the left atrium. So, it is lying posteriorly across the, like very much pushed towards the interatrial septum. Okay, now these are the main two structures which are helping in the generating of impulse as well as conducting of the impulse. Now, as a very quick point, how do we remember the function of this structure, this SA node and AV node? At once we can say that SA node is the pacemaker. Why we are saying so? We will discuss about it. AV node is called the gatekeeper. Okay. Now after this, from the AV node down below along the interventricular region, along the interventricular septum, possess a bunch of bundle which is called the bundle of His. Okay. Now this bundle of His on either side again branches out into the Purkinje fibers. Okay. Going by the function, the bundle of His, it is for the conduction of impulse from the AV node. Okay. Purkinje fiber, it conducts impulse, that is the wave of depolarization, all the way to the posterobasal region of the ventricles. Okay. Now this Purkinje fiber, it also penetrates and gives out this branches which are called as the fascicles. Now these fascicles are present both in the left as well as in the right side of the ventricle, both in the left ventricle as well as the right ventricle. Now the important point in context to the conducting zone, what we have to remember is that SA node is the pacemaker. Means it can show the autorhythmicity. Rather, it does shows the autorhythmicity. It shows autorhythmicity. Means it can generate its own impulse without getting any command from the central nervous system. The brain is not sending any impulse to the SA node to generate impulse, but the SA node itself can show autorhythmicity. Now the reason behind it is that this SA node is made of P cells, which is the pacemaker cells. This SA node generates the autorhythmicity or the heart rate at a rate of 80 to 100 beats per minute. It is its capacity. The SA node can generate the autorhythmicity at 180 to 100 beats per minute. This is its capacity. This is how much it can generate. But the ultimate rhythmicity is 70 to 80 beats per minute. SA node, though it has the capacity to generate 80 to 100 beats per minute, if it is left alone on its own, it still generates a beat which is 70 to 80 beats per minute. Now talking about the other structures that can generate the autorhythmicity. See, all the structure, the whole of heart, it's one of the special characteristics is that it's not only the SA node, but the AV node, the bundle of His, the Purkinje fiber, each and every structure of this conducting zone has the capacity to generate the autorhythmicity. So AV node, which is also an important structure of the conducting system, it can generate a rhythmicity between 40 to 60 beats per minute. Okay, the bundle of His and Purkinje fibers, it can generate at a rate of 15 to 40 beats per minute. So here we can see it is the SA node which is the pacemaker because it is generating the highest number of beats. Why SA node is the pacemaker? Another important point, it is saying that SA node has the steepest pre-potential. Details about it we will study in the upcoming prep. So since it has got the steepest pre-potential, this is also one of the reasons why SA node is the pacemaker. Okay. Now coming to the structure that is involved in the conducting of the impulse that is generated. So if we get the diagram again, so and we use it to understand the same. Now see here, as we know, this is the right atria, that is the left atria. So here the SA node which is on the right atria, this is what is generating. This is this SA node, it generates the impulse. So once this SA node generates the impulse from the right atrium to the AV node, this impulse is passed by or through the three internodal structure. The three internodal structure that through which the impulse passes from the right atrium to the AV node, that is the start of the ventricle also. This is the anterior bundle of Bachmann. Okay. Then the intermediate internodal bundle of Van-Keeback. Okay. And last is the third one is the posterior bundle of the Thorel. It is through this three internodal bundle that impulse is transmitted from the SA node to the AV node. Now, once the impulse comes and reaches the AV node, once the impulse comes to the AV node, it gets delayed or it just sits or stops in the AV node by 0.09 second. Now this is called as the AV nodal delay. The phenomenon due to which the impulse after reaching the AV node, it just sits on the AV node before getting conducted to the ventricles via the bundle of His. It takes a time of about 90 millisecond or 0.09 second, which is roughly like 1 second. Now, this is called the AV nodal delay. AV nodal delay. Okay. What is the importance of it? What is the significance of it? The significance of it is that AV nodal delay helps in the healing of blood into the ventricles. It is for this reason why the AV nodal delay happens. Now, after the AV nodal delay happens, next the course that is followed is, we'll understand from the diagram. So here, if we look at the diagram, we will see that after this impulse passes on to the AV node, from AV node, the next course of conduction of impulse starts. So from this AV node, via the interventricular septum, this impulse is what? This impulse is nothing but it is the wave of depolarization. So this wave of depolarization first travels through the interventricular septum, and the first part of the heart, of the ventricle part of the heart that receives the wave of depolarization is the left endocardial portion of the ventricle. So if we write the whole process in the flowchart part, it is like SA node generates impulse, right? Now that impulse goes to AV node. Then what happens is AV nodal delay, and after that the impulse forces down the wave, the action potential wave travels through the interventricular septum, then it depolarizes the left endocardial region of the left ventricle, then right ventricle, and lastly via the Purkinje fibers, it depolarizes the posterobasal region. Okay, it just swaps up. It just, via this fascicle, it just swaps up in the posterobasal region, as we have seen. Now, this wave of depolarization and repolarization, as it reflects in the ECG, are as this, are as follows. This ECG. Like this P wave, as we can see, this is when the atria receives the wave of depolarization, and the complex, the QRS, is designating the contraction of the ventricle. Now, details about the waves we will study in the next lecture in the ECG section. And lastly, when the ventricles, the maximum 2/3 of the ventricle undergoes the wave of depolarization, we get this QRS complex, and lastly, it is the T wave that signifies the repolarization of the ventricle. So, conduction of the impulse. It starts with the SA node, goes to the AV node. As we see here, starts with the SA node, goes to the AV node. Via the bundle of His, it is spread across the ventricle, and lastly, the posterobasolateral region is swapped by the bundle of His these projections, which are the Purkinje fiber. Now, the speed, the rate at which this impulse is conducted is variable. It is not the same. So, if we write it, the rate of impulse conduction, basically, it is the speed of the impulse conduction in meter per second. If we write it, then first is the SA node. So SA node, it is a generator of impulse. It is not conducting, it is the speed is 0. Okay. Second is the AV node. Okay. Now, within the SA node, the speed is 0. But when it has to come from SA node to AV node, it is 0. It is 0.05. It is very, very fast. Okay. Now, next from AV node, the impulse that gets conducted, it takes the least time, the minimal time. Okay, which is about like 0.02. Okay. It takes the very, very least time. Okay. The unit of the speed that we use here is the second. Okay. This is the time we are talking about. Here on the side, we are going to write the speed also. Now, the speed at which the AC node conducts the impulse, it is about 0.5 meter per second. AV node also roughly takes the same time, but it happens only after the nodal delay. Only after the AV nodal delay, the speed that AV node takes to conduct the impulse is also roughly the same. Next structure, it is the bundle of His. Here the impulse like takes about 0.12 second. Okay, and the speed at which the impulse is conducted, it is 1 meter per second. The fourth structure is the Purkinje fibers. Again here the speed is 0.12 to 0.16 second, and the speed here is the fastest. The speed of conduction is 4 meter per second. Now, what is the reason? The reason for AV node to take long time for conduction of impulse, it has more gap junction. Okay, it has less diameter of the fibers. The cardiomyocytes, the fiber it has, the muscle fiber, it has got smaller diameter. These are the main two reasons why the conductivity is slow at the AV node. Now, coming to the action potential. The action potential of the cardiac muscle are mainly of the two types. So, we are going to write it like cardiac potential and the pacemaker potential. Now, one thing about this cardiac potential and the pacemaker potential. Okay. Before we go on to the understanding the graphs of it, two important things we have to understand. Here, SA node, AV node, bundle of his and Purkinje fibers all have the capacity to generate impulse. Okay, all have the capacity to generate impulse. But when we talk about the nodal tissue, we mean the SA node and the AV node. Here, the action potential shown by the cardiac muscles, that is the atria and the ventricles, and also the Purkinje fiber, okay, are the fast type, SA node, and that is a nodal tissue, and AV node show the slow type of action potential. Okay, SA node and AV node, they show the slow type of action potential, whereas this atria, ventricle, Purkinje fiber, they show the fast type of action potential. Now, there is a whole lot of ionic reason for this basis and why they are different. The first point that we must be wondering, that though like SA node, okay, SA node is a pacemaker, AV node is a pacemaker, then why is that SA node is a pacemaker? One reason we have heard, the stupid potential that SA node has got, but why again only the SA node can discharge impulse at a rate of 70 to 80? What did I tell? Actually, the SA node has a capacity to discharge at the rate of 80 to 100. 80 to 100, but ultimately it discharges at a rate of 70 to 80. This is just a very quick reminder, and this is something that we have to remember. Okay, so SA node maintains the heart rate at 70 to 80 beats per minute due to vagus nerve. Now, vagus nerve innervates the structures of the cardiac muscle. It is present in the heart also. So, it is because of the vagus nerve, instead of the SA node discharging the impulse almost 100 times, it maintains at a rate of like 70 to 80 times. This is one point. Now, second point is that why is the SA node the pacemaker? Second, SA node has overdrive suppression or override suppression or over, both the same actually. The mention you find in a different way in different literature. So it has got a overdrive separation or override separation, because of which SA node is the pacemaker, means it suppresses the discharge from the AV node or bundle of his as long as the SA node is intact. Okay. Now these are the points that we have to remember in context to the SA node. Now coming to the graph, understanding the graph. So there are this fast type and there are this slow type of graph. Okay. Here, if we see the fast type, the first one as we see on the left side, the fast response and the slow response is the fast type and the slow type. So in the fast type, we have got distinctively five regions, five areas of the action potential. Like the first is the zero phase, then we have the phase 1, phase 2. So here you see in the phase 1, it is actually kind of a hitch. It is actually kind of a like incisura that you see here. Phase 2 is like a flattened out, more or less. It's not a total cut off flattened out, but it's more or less like a plateau kind of a thing. Whereas phase 3 is a rapid fall, which signifies the depolarization. And then again we see the phase 4, which is the straightened out. So going by the phase 0, which is an upward linear stroke. Upward linear stroke is obviously our wave of depolarization. I'm just writing in a short form, depolarization. So 0 is the depolarization, and it is from the first phase that repolarization starts. Okay. And phase 2 is also repolarization. Phase 3 is also repolarization. And here the phase 4 is the back to the resting membrane potential. So these are the 5 phases in the fast type or the fast response. And again, where do we see the fast response? In case of a cardiac muscle, we see in the atria, we see in the ventricles, and also we see in the Purkinje fibers. These are the structure where the action potential is in this 5 phases. Okay. Coming to the slow response. In the slow response, what do we see? We see the structure is like, it's like a peak, but it's not at all a sharp peak. Like it's not at all something like this, right? That we saw in the action potential of the skeletal muscle. No, it is not like this. How is it? It is like a peak that has an upward stroke and a downward stroke, but it is not very, very specific. So specifically, the points that we have here are 1, 0 phase, 2 phase. In most of the graphs we don't mention the 2 phase because the whole of it we can also just sum it up and tell as a phase 3. Okay. And then we again have our phase 4. So the slow response is manifested in what? In the nodal tissue, in the SA node and the AV node. Now we are going to take one by one this graph and we are going to understand in details. So going to the first picture. This is our, let's see, the first graph, which is our fast response graph. The fast type or the fast response. The fast response. Okay. Going by the ionic basis of the action potential. The ionic basis. Okay. The ionic basis. So it starts with the 0 phase. As we have studied here, see the 0 phase. The 0 phase. So phase 0. Phase 0. This is the wave of depolarization. So in case of the atria, ventricle and Purkinje fibers, What causes the wave of the depolarization? What causes the wave of the depolarization? It is influx of sodium via the voltage gated sodium channel. Via the voltage gated sodium channel. This is the reason why we get this straight upward spike, straight upward line. Now, here the resting membrane potential, the resting membrane potential of myocytes are minus 80 MV. Now, if you look at the graph, you will see the maximum point that this zero phase has opened up, has like touched, has like reached. It is about maximum the action potential reaches up to plus 35 millivolts. So here you see the ionic phases, and the reason for the wave of depolarization is pretty much same like that of the nerve fiber and the skeletal muscle that we have studied, right? It is pretty much the same. So after that, what happens as soon as this phase 0 gets over and it reaches to a maximum level of, say, this one is plus 35 millivolt, immediately there is closure of the voltage gated sodium channel. Here it is seen that the voltage gated sodium channel closes after 1 to 2 millisecond, and then the wave of depolarization stops. Now here the pharma link point to remember is that here tetrodotoxin from, it is a toxin from puffer fish, can lock these sodium, that is a voltage gated sodium channels. Okay, this is all about our phase O. Now coming to the next phase, that is the phase 1. That is a phase 1 or the incisura kind of a thing. This incisura kind of a thing. So this is the next phase, phase 1. The repolarization begins here. Now, what is the reason behind it? Here, the potassium efflux begins. Obviously, the sodium channel closes, the voltage gated sodium channel closes. Okay, and the potassium efflux begins. The outward movement of the potassium happens. This is the phase 1. Now, these potassium channels, okay, can be blocked by amino pyridine. This is a point to remember. It can be blocked by the amino pyridine. The next phase, which is the plateau out phase, this is the phase 2. This is the plateau. Relatively, you see a straightened up, a plateau kind of a structure is there. This is the phase 2. Now, what is the reason? Ionic basis of this phase 2? Phase 2, here what happens? This is a polarization phase. At the basis of ion, what is happening here? Potassium efflux continues via the rectifier channels, and important phenomenon is that the L calcium channels. Which calcium channels? The L calcium channel, which is also the dihydropyridine receptors. Okay, they open up and influx of calcium happens. Influx of calcium happens. The important point in context to that to remember is these calcium channels can be blocked by verapamil, the calcium channel blockers, verapamil. Okay, this is what is happening in the phase 2. Now, there is a rapid repolarization, like you can see a rapid fall. All of a sudden, it falls like steeply. It is falling very fast and very steeply. It is falling. So, this phase 3, this phase 3, it is rapid repolarization. So what is the ionic basis in this repolarization? As we can see, rapid efflux of potassium happens via the transient inwards and also outward rectifier channels of potassium. Okay, this is what actually it does. Now here many anti-arrhythmic drugs can act. This is what is happening in the phase 3. Coming to the last phase, that is the phase 4. I am encircling it because it will make sure that the cell comes back to its resting condition, that is a resting membrane potential. So, the lane or the phase 4 is the return to resting membrane potential. Now, what is the ionic basis of this resting membrane potential? Here, one more thing is happening. Calcium channels closes. Okay. Now, here, return to the resting membrane potential. What happens? Efflux of potassium slows down, the conductance slows down. Sodium potassium ATPase pumps to restore the resting membrane potential. Okay, this is the ionic basis. Now, very quickly for the revision parts, if we have to remember, so zero phase. What is happening in the zero phase? Sodium influx. As usual, Sodium influx. Okay. What is happening in the beginning of the repolarization phase? Potassium efflux and closure of sodium channels. Okay. Second part, what happens? Potassium efflux and calcium influx. Third, what is happening? Potassium efflux and closure of calcium channels. Here what happens? Potassium efflux almost stops and sodium potassium ATPase acts to bring the resting membrane potential back to the normal. These are the phenomenon, or this is an event that has happened or that is happening in the fast response. Now coming to the slow response. Let me write first. Coming to the slow response. Okay. Here in the slow response, this is a graph for the slow response. Okay. So the phases in the slow response are, we have the zero phase. Okay, we have the zero phase. We have the phase 3, and then we have the phase 4. This one, which is the phase 4. Now here, in context to this slow response, we know slow response are manifested or seen in the nodal tissue. That is the SA node and the AV node. Now we will start with the phase 4. Now this is pre-potential phase. This phase is the pre-potential phase or the pacemaker phase. Here, phase 4, this is actually the resting. I highlight because lot to understand about it. It is the resting phase in the nodes or nodal tissue. If we look very closely to this phase 4, which is the resting phase. So here you see the resting phase of this nodal tissue. It is not actually resting. Like what have we seen in the nerve cell or any other excitable cell? Whenever we saw the resting membrane potential, the resting phase was like this, like linear, right? Or even in the fast response. Why go so far? So here in the fast response, the resting phase is like static, it's like linear. Whereas here you see the resting phase is not actually quiet. It is something like uprising. It is not resting, but this is not resting, but it is like uprising. It is uprising, means it is unstable. This is the resting phase. So what is the ionic basis of it? What makes it unstable so much? The phase 4 has the influx of sodium. What does it have? It has the influx of sodium. Now, this influx, it is very, very different from what we saw in the wave of the depolarization. This phase has the influx of sodium via the epithelial sodium channels, okay, which is also abbreviated as E-net channels. And these channels are point to remember, that's why I'm putting a star, not voltage gated. One important point. Second important point, this channel are open only when the cells are hyperpolarized. When the cells are only hyperpolarized. So, thus, the current generated in phase 4 is called funny current. So why it is called funny current? Because it is very strange that only when the cells are like hyperpolarized, like you can see it is like -60, it is like hyperpolarized, only then those sodium channels which are not voltage gated, they open up. So that therefore those sodium channel, therefore those sodium channels are called hyperpolarization induced sodium current channels. Okay. So the event that happens in the phase 4 at once, if we write, it is funny current generation. So once the funny current generation is there, the sodium starts entering because the hyperpolarized state has opened up the sodium channel. There is decrease in the resting membrane potential. The influx of sodium causes this -60 to go all the way up to the threshold level, that is -30, from which it shows the firing and goes to the phase 0. Now, phase 0, what happens in the phase 0? In phase 0, it is the depolarization phase. Phase 0 is the depolarization phase. And what is the ionic basis of it? There is rapid calcium influx. Okay, we'll connect to the previous phase now in relation to the calcium also. Now, rapid calcium influx happens via the L channels. Okay. Now, here in the phase 0, there is rapid calcium influx via the L channel. Now, we have seen that there is gradual rise in the resting membrane potential. Now, this funny current generation alone is not enough for the depolarization firing to happen. Here, also calcium influx occur via the transient or T channels. So here the influx happens via the T or the transient channel. So those two together pushes the action potential in the nodal tissue to the zero phase. And in the zero phase, there is rapid influx of the calcium. So the main event that is occurring in the zero phase is the calcium influx. That is the main reason. Now, since the action potential that we get in the nodal tissues due to the influx of the calcium, this pufferfish toxin like tetrodotoxin cannot block this phase of the action potential. Now, next is the phase 3. In case of a nodal tissue, the phase 1, 2 are kind of merged with the phase 3. There are no distinct or definitive phase 3. Phase 1 or phase 2, there is only a distinct phase 3. So, phase 3, this is the repolarization phase. Now, what is the ionic basis of it? The ionic basis is that rapid potassium efflux and closure of the calcium channels. So, remember when it comes to SA node and AV node, sodium influx happens only in the prepotential. Only in the prepotential. It does not happen in the depolarization phase, and this is called as the pacemaker potential. This is what we know as the pacemaker potential. Last, here comes the restoration of the phase 4, that is the pre-potential. What takes back? What takes back this nodal cell back into phase 4? Phase 4, what is the phase 4? This is again pre-potential. So what is the ionic basis of the phase 4 here? The ionic bases are multiple. First, obviously, potassium efflux continues, but that alone is not enough. Here, the sodium, potassium ATPase pumps additionally to remove, because in the phase 0 there has been so much of influx of the calcium via the L channel. So here additionally the calcium sodium exchanger, like 3 sodium and 1 calcium pump or the ATPase pumps out 1 calcium ion and 3 sodium gets influxed. So that way the phase 4 is again restored back in case of the cardiomyocytes. Okay, this is the ionic basis of the fast response as well as the slow response. Now at the beginning of the lecture itself, we have understood and we have studied that this autorhythmicity is due to the P cells, right? Due to the P cells, and it has got nothing to do with the sympathetic or parasympathetic innervation, or it has got nothing to do with the central nervous system. But there is a effect. There is effect of autonomic nervous system on the pumping activity, especially the ventricles, especially in the ventricle. When we tell the pumping activity, we mainly mean the ventricle. So it is seen that it is seen that sympathetic innervation to the sympathetic and parasympathetic innervation to the SA node is on the right side of the heart. Okay. And to the AV node is on the left. Another point that we know is that stimulation. So since the sympathetic and parasympathetic to the SA node, because SA node is a structure that is present on the right side of the heart, so this innervation is also on the right side. So stimulation to the right vagus. Now since right side we have the SA node, in case the right vagus is stimulated, what does vagus nerve have? Vagus nerve have inhibitory effect, right? And the sympathetic nerve, it has got stimulatory effect. So stimulation to the right vagus decreases the heart rate. Okay. Whereas stimulation to the left vagus, because left vagus innervates the AV node, and AV node, what is its main function? Its main function is to conduct the impulse. Conduction of impulse is the main function of the AV node. So stimulation to the left vagus, it prolongs it prolongs the time of conduction of impulse. Means the speed of the impulse conduction becomes slower. Okay. Now the opposite will happen if the left side is like stimulated, right? If the right and the left side of this vagus nerve and the sympathetic nerve is stimulated. Now overall we know that the sympathetic innervation has stimulatory effect and parasympathetic innervation has inhibitory effect. Now, these effects are on what? These effects are on the heart rate, on the excitability, on the speed of conduction, and also at the rate of contraction, the force of contraction. Now, there are certain specific terminologies, certain terms that we use to understand all this, like whether there has been increase in the force of contraction or there has been decrease in the heart rate, heartbeat, all these things. So there are certain terminology which we will discuss. Now overall, ionotropic chronotropic. The terminologies we are talking about: bathmotropic and dromotropic. Okay. Now, what does the term ionotropic mean? Ionotropic mean force of contraction. See, for the contraction, what we need? We need the ions, we need the essential ion, calcium. So, ions, ionotropic means force of contraction. So, if there is increase in force of contraction, we call it positive ionotropy or positive ionotropic condition, positive ionotropic reaction. Okay. If there is decrease in force of contraction, we call it negative ionotropy. Okay. Chronotropy. Chronotropy means the heart rate. Similarly, increase in heart rate is called the positive chronotropy, and decrease in the heart rate is called negative chronotropy. Bathmotropy. Bathmotropy means the excitability, like how fast the cells are excited. So this cardiomyocytes, right? The cardiac cells. It is excitability. So increase in excitability is positive bathmotropy. Similarly, decrease in excitability is negative bathmotropy. Okay. Dromotropy is the conductivity. So, increase in conductivity is called the positive dromotropy, and decrease in conductivity is the negative dromotropy. These are the terms that we use. Now, there are certain drugs that are causing increase in this inotropy, dromotropy, bathmotropy, and there are certain drugs which decrease all these parameters. It is seen that like drugs that increase ionotropy, chronotropy, increase ionotropy, increase chronotropy, increase bathmotropy, and increase chromotropy are the circulating catecholamines, are circulating catecholamines, beta adrenergic agonist, beta adrenergic agonist, or muscarinic receptor antagonist. the agonist, like the drugs that will block the activity of the vagus nerve manifestations. Okay, they will all increase the parameters of the heart. Now, similarly, drugs that will decrease the cardiac functions. What are the drugs that will decrease the cardiac functions? Those are the beta channel blockers. They are the calcium channel blockers, and they are the muscarinic receptor agonist. Okay, these are the drugs that will block them. Now, there are certain drugs that will act on the specific channels that we have studied. Once we have studied name of the drugs while studying the action potential, again we will study in a tabular form with certain example for our better remembrance and better understanding. So, drugs targeting various channels in the heart. Okay, what are the drugs targeting the various channels in the heart? Like sodium channel blockers. Now, there are like more than one type of the sodium channel blocker. Example, class 1A, procainamide. Okay, class 1B, lidocaine. Class 1C, lecainide. These are the drugs that blocks the calcium channel, the sodium channel, which is the voltage gated sodium channel, and they act on the these drugs act on the fast type of response, means they will modify the functions in the ventricular muscles mainly. Okay. Second, we have the sympatholytics. Sympatholytics, like the drugs that will block the B-adrenergic receptor or B-adrenergic receptor activities. Okay. So they are like propranolol group of drugs. What are they? They are targeting the beta adrenergic receptor. Third, Third, we have the potassium channel blockers. This potassium channel blocker, they also mainly target the fast response type, like amiodarone. Okay. Fourth, we have the calcium channel blocker. Example, Verapamil. These are the various drugs and on specific which channel they act. Okay. Coming to the gauge theory. What is the gauge theory? Now, this is very interesting as well as very important also. After this gauge theory, we are going to discuss a few clinical conditions also pertaining to the one that we studied, the things that we studied. Now, what is the gauge theory? This concept of gauge theory, this concept is about the, it is about the voltage gated sodium channels. Now, you may wonder why over and over we have been studying about this voltage gated sodium channel so much. See, when it comes to the cardiac function, the cardiovascular function, the function of the heart, it is the ventricle which are the pumps, right? Atria are the capacitor. They just receive. They're kind of a receptor of the blood that they receive from the systemic circulation and pulmonary circulation, and they pass on to the ventricle. Now, it is the ventricle which is pumping this blood to the periphery and the pulmonary circulation. So, for the ventricles to contract, what is a contraction? As we studied, it's a mechanical event. So, before the mechanical event, what should happen? The electrical event, that is the action potential. So, influx of the sodium in the ventricle to start the action potential is very, very essential. Okay, it's utmost important function of the heart. Heart is nothing but the pump. Its main integrity is because it has to act as a pump the blood to the circulation. Now, what does this voltage gated sodium channel gate theory proposes? The gate theory says that influx of sodium happens through the voltage gated M gate of the sodium channel. So if we draw this, it will be, so this is the cell membrane. So this is the cell membrane. I'm just drawing short for our understanding. And this is like in normal condition, this is how the sodium gates are. This is of course hypothetical thing. This is the voltage gated. This is the voltage gated sodium channel. Now, of this voltage gated sodium channel, this is the M gate in the sodium channel, this part which is facing the ECF, and this is facing the ICF. So this is the M gate of the channel, and the one that is facing the ICF, it is the H gate. Now, this is the way the sodium channel is closed. Now here, what we see is that the sodium channel is closed. The voltage gated sodium channel is closed. Now, upon stimulus, whenever there is any stimulus, means the wave of depolarization, means the threshold level intensity stimulus, the threshold level intensity stimulus, then what happens? What happens is something like this. This M gates of the sodium channel, the M gates of the sodium channel, they just open up. They just open up. So when they open up, there is influx of the sodium. Sodium from the ECF enters the ICF. Okay, that is in the inside of the cell. This is like the M gates have opened up. So the M gates are open. So through this M gates, the sodium has entered. Okay. Now, once the repolarization starts, then the same sodium channel, what it does when the repolarization starts, the sodium channel, what it does is, here the M gates are open. They haven't shut down. They did not fall upon each other and they did not close down. They remain open only. What happens is that now it is the H gate. It is the H gate that closes down. So here you see the M gate is open, yet the H gate has closed down. As a result of which, the sodium, even if it is present, it cannot enter. So this is the gate theory. Gate theory means in resting condition, the M gates are closed and H gates are open. Upon stimulus, it is the M gates that open and there is influx of sodium from the ECF to ICF. Again, when the repolarization has to start, or we can say like, since this voltage gated sodium channel, they are very short lived, they cannot stay open for a long time. After some time, it is the H gate that has closed down, but the M gates are open. That's why this sodium cannot enter. Only after repolarization and resting membrane potential is re-established, then again the initial state happens. Meaning what? Again the M gates goes to its original configuration and the H gates open. Okay, this is the ECF, this is the ICF, this is the gate theory. Now, why this gate theory is important? Again, we have studied about it. The significance, what is its significance? The significance is that toxins like tetrodotoxin, and many anti-arrhythmic drugs target and blocks the activity of these sodium channel gates. This is its significance. Okay. Apart from the innovations, apart from all this thing that we have studied, there is also effect of hormones, effect of bile, and temperature on the heart rate. Now, what are the effect of this hormone and effect of this temperature on the heart rate? Hormones like thyroid hormones increases the heart rate. When the heart rate in an adult is 100 and more, it is called tachycardia. Example, in thyrotoxicosis. Whenever there is increased quantity of the thyroid hormone that is circulating in the blood, it causes increase in the heart rate, a condition called as thyrotoxicosis. Second condition is the bile salts. Increased quantity of bile salts reduces heart rate. So when the heart rate is actually 60 and below, we call it bradycardia. Okay. Third is temperature. Now, all fever, that is increase in temperature, which is hyperthermia, except typhoid fever increases the heart rate. Okay, these are the effect of the hormones by the salt and the effect of the temperature. Okay, which we have to remember. These are the various effect of these agents on the heart rate. Okay, so lastly, we will discuss some clinical condition which affects the functioning of the heart. Like to start with, we will insert the picture which will help in the better understanding of what we were talking. So, this is a graph that signifies or that shows the condition of the nodal cell, the pacemaker, the SA node, which is node, which is during in three states. One, when it's manifesting the normal activity, when it is rendering out or when it is causing a normal beat, as we can see in this middle graph. So a normal heart rate which is given out by the SA node after it generates an impulse is like this, like the slow type, exactly like what we have studied. Now, when the same SA node is stimulated by the sympathetic nervous system, which is a branch of the ANS as we studied earlier, here we see the heart rate is increased. Now the point at which the sympathetic innervation act is at the pre-potential phase. It is at the phase 4. So here you see under the activity of the sympathetic nerve, the phase 4 is like shortened. The phase 4 is shortened. Okay, the phase 4 is shortened. The peak is taller. The rate is like taller, longer, and the duration is reduced compared to the normal heartbeat. Under the influence of the vagus nerve, if we see the same graph under the influence of the vagus nerve from the diagram, here we see the phase 4. It is like prolonged. It is like prolonged and more steep. So here under the influence of the parasympathetic nerve, the phase 4 is long, prolonged, and is steeper, as a result of which there are more gaps between the two heartbeats, causing reduction in the heart rate, Now, there is a condition that affects the conducting capacity of the AV node. Clinical link. If there is presence of any extra bundle, like bundle of Kent, in the conducting pathway, then the time of conduction of impulse becomes very long. Okay, the details of it we will study in the ECG. For now, remember, if there is any extra bundle that appears to be somewhere between the atrium and ventricle, maybe in the anterior septal region or the posterior lateral region, right lateral region or left lateral region, that will cause like prolonged conduction of the impulse. Okay, but on the other side, it will result in extra systole due to entry of current via the accessory pathway into the ventricle. So this we are going to understand with a diagram. the picture. So we choose this picture and say, for example, here this is the structure where we study the normal conduction of impulse, right? So now say, for example, in this region there has been a generation or development of an extra accessory pathway, which is the bundle of Kent. And this bundle is quite capable of conducting the impulse because it is also an abnormal development of the cardiomyocyte. So what will be seen is that the impulse, like once it reaches, I'm drawing on one side, I'm not showing the right side because we're understanding this abnormal pathway. So when it traverses via the bundle of hills and enter through the posterobasal region, now it should wear off. It should stop at this region, right? But it won't stop when it finds that there is an accessory pathway in the left lateral area, so it will enter through this region and go back to the atrium and circulate again into the ventricle. So like that, there will be re-entry of the impulse before time. Whereas the original impulse will take long time to reach, where because it is following the normal pathway. Whereas this extra presence of this extra bundle which is capable of conducting impulse, it will cause the re-entry of current round and round to the atria, then again from the atria via the bundle of hills along the interventricular septum again back to the ventricle, resulting in a premature contraction of the ventricle. So that way the pumping capacity of the heart will be less and less. Okay, this is one clinical condition. Another clinical condition, second example, that affects the cardiac potential is as seen in coronary atherosclerosis. So what happens in coronary atherosclerosis? Here, due to blockage in the coronary artery, a part of the cardiac muscle not get enough perfusion, that is enough blood. So the area that is under perfused means it is not getting enough blood starts to die, like necrosis starts happening. In that case, what happens? The potassium from the necrotic site, that is the area in the cardiac muscle that is not getting enough blood supply and it is dying, moves to the near interstitial fluid. So there is accumulation over a period of time. There is accumulation of potassium in the nearby interstitial fluid surrounding the damaged area. Surrounding the damaged area. As a result of which the slow type response becomes predominant. Means what? Means what? If I write it in simple word, because the cardiac muscle is not receiving enough blood, cardiac muscle means what? This is a damage that has happened to the ventricle or atrium, mainly the ventricle. So, in the ventricle, what happens? That is the fast response of the affected cardiac muscle, because atrial, ventricle and Purkinje fiber shows the first type of response of action potential, right? 0 to 4 phase. This muscle changes to the slow type because of the inadequate perfusion of the blood. Okay. So from the beginning, if we are to see what all we have studied today, this was the first introductory class and discussion of the conducting system of the heart. We started with the parts of the conducting system of the heart, the nodes, the bundle of hairs, the Purkinje fibers, why SA node is the pacemaker, and what makes it the pacemaker? It is the steepest free potential that it has got. Then we studied the path of the conduction through the heart, followed by the speed and the time taken by it. And then in details, we have studied the various phases of the action potential, both the fast type seen in the cardiac muscle and the slow type that is seen in the nodal tissue with the pharma link as well as the clinical link. Then we study the effect of the autonomic nervous system branches, that is the stimulatory from the sympathetic and inhibitory from the parasympathetic in details. Then the drugs that are targeting the various channels, and also at last we discuss the gate theory, followed by the effect of the hormone bile and temperature, and lastly we discuss two clinical cases in context to the conducting system. Okay. So next class, we would be starting with the ECG, understanding what is ECG, how the ECG leads are oriented, and what are the various waves in the ECG and their significance and their clinical orientation. So that's all for today. I will see you all again next Monday. Okay, till then, bye. Good night and bye to you all.